Hello, everybody. I am Dr. Dana Gibbs. Welcome to the Tuesday Live. I'm your local thyroid and hormone expert. And today we have a really special treat. I have Dr. Nabila Noor. She is a practicing board certified fellowship trained urogynecologist and reconstructive pelvic surgeon. So what that means is that in her practice, she takes care of women with a variety of pelvic floor disorders such as incontinence, pelvic organ prolapse, fecal incontinence, fistulas, just to name a few that can really affect a woman's quality of life. She is passionate about education and practicing evidence-based medicine and offering the most cutting-edge, minimally invasive surgical techniques to her patients to help them recover faster and get back their quality of life. Her education was first at Smith College, which is an all-women's college, so that sparked her interest in women's health and advocacy. And then Duke University School of Medicine. Following medical school, she completed her residency in obstetrics and gynecology at the Icahn School of Medicine at Mount Sinai, and that is in New York. And then Beth Israel Deaconess Medical Center, Mount Auburn Hospital, affiliated with Harvard. So she currently practices at Lehigh Valley Health Network in Allentown, PA, where she has a busy and thriving practice. So, Dr. Noor, welcome. I am so excited to have you here. This is going to be great fun.
Thank you so much, Dr. Gibbs, for that wonderful introduction. I am so excited to be sharing this platform with you as well. And I know we've talked about this a lot. There's so many things to discuss, but I am excited to get started. Okay. So yeah, one of the things I will say, because this is a question I get all the time, is that, well, what is a urogynecologist? Like, what kind of patients are you seeing? Because, we're a relatively new field. Believe it or not, we actually became a board certification in 2013. So as you can imagine,
compared that's not very long. Yeah.
Not at all. So as you can imagine, compared to some of the other specialties, we are like a little baby. And I think what happens as a result of that is there's a lot of confusion about what a urogynecologist does. And even among healthcare providers and sometimes even physicians who may not have had a lot of exposure to urogynecology. So I kind of wanted to bring it out there and just say that,
that's really great, because I finished residency in 1999. And so, urogynecology is something that did not exist when I went through my gynecology rotations, and certainly not when I was in residency. It's nothing I was exposed to at all, being ENT. So tell my audience about yourself and how you got interested in urogynecology in the first place.
Yeah. So as you mentioned, you kind of mentioned a little bit about my training, but, my interest in, like I said, in women's health really started when I was in college. I always knew I wanted to be a physician, but I wasn't quite sure what part of medicine I wanted to go into. And then women's health was something I was interested in. And then once I graduated medical school, I knew I wanted a practice, or I wanted a specialty that combines both medicine as well as surgery. And at the time, obstetrics and gynecology seemed like the perfect amalgamation of both medicine and surgery, because it really allowed you to explore both the avenues, as well as build that, relationship with patients where you're following them for a long period of time. But when I was in a fourth year medical student, I actually did an away rotation in Bangladesh, where, even in medical school, I had no idea about urogynecology. But when I did that away rotation at the time, unbeknownst to me, we ended up taking care of women with something called pelvic organ prolapse, where essentially, because of weakness of the pelvic floor support structures, your pelvic organs, which could be the uterus, the bladder, the rectum, sometimes is pushing through. As you can imagine, can be really debilitating for women because it really affects their quality of life. So we end up doing these surgeries with, at the time with some urogynecologists and gynecologists. And I remember thinking, like, oh my God, we do these 1-hour surgeries and this woman's life is completely changed, because now she has a normal anatomy. She's not dealing with the self-conflicting issues about her body image. It could be a big taboo in some societies, which is, where I was at the time. So it really made me realize what an impact this specialty can have. And so that's kind of what sparked my interest. And then, of course, I was really fortunate when I was in my residency to have good mentors who encouraged me to do this. And here I am talking to you about it.
Right. Wow, that is really very, very cool. Well, I mean, the reason that I got interested in talking to you in the first place is because I deal a lot with hormone loss, and hormone
Yes.
loss happens, not only to women at menopause, but it happens in the postpartum period, and it
Yes.
happens to women who have taken certain kinds of birth control for a really, really long time. They will
Yeah.
lose their estrogen levels, and it leaves them susceptible to a lot of these conditions that you treat. So tell us more about what kind of patients you see in your practice today.
Yeah, no, I think you're absolutely right. And I think that's an important point because, in general, the perception is, oh, urogynecology is for patients who are menopausal. But I think you hit a very good point because it can happen to young women right after they go through a delivery because, we're in that phase where our estrogen is low. So what we call hypoestrogenic state. So a significant portion of my patient population are women in their 30s and 20s and 30s, just right after they had children. So, in general, as a urogynecologist in my practice, I see a whole gamut of patients. So, I see patients who may have urinary leakage with laughing, coughing, sneezing, exercise, pretty much anything that puts pressure in their abdomen. So, this is known as stress urinary incontinence. I also
Mm-hmm.
have patients who have a lot of urinary urgency, frequency, not being able to make it to the bathroom. So, that's known as overactive bladder. I have women who have accidental loss of bowel, so something we call fecal incontinence. And as I was mentioning to you earlier about what got me interested in urogynecology, so pelvic organ prolapse, where literally women feel that they have a ball or a bulge coming out through the vagina because of the laxity. It's almost like a little hernia. I also
Wow.
see a lot of patients, for example, women suffering from recurrent urinary tract infections, bladder pain, pelvic pain, a fair amount of reconstructive work that involves trauma, maybe from childbirth, or things like fistula, where it's basically a false connection that can develop either between the bladder, the vagina, or the vagina and the rectum, either from previous
How
surgeries or trauma
awful. Oh
during
my goodness.
childbirth. Yes, as you can see, it's a whole gamut of conditions, but it can
Mm.
really be debilitating. And I think,
Yeah.
something that I always tell my patients, and I'm always kind of, even anybody that I talk to, I tell people is a lot of the times women are told that some of these conditions that we treat is normal for aging. There's nothing normal about
Oh,
leaking urine. There's nothing normal about
no
leaking stool.
way.
Not at all. And yes, maybe, 20, 30 years ago, we didn't have some of the amazing treatment options that we have now. But now that we're a whole other subspecialty, there's lots of different options that we can talk about. And I think that's where, like you mentioned at the beginning, like I'm so passionate about what I do and talking about it because I really do think that we're doing disservice to our patients by not reaching out to them.
Yeah, no, I agree with you 100%. So one of the big topics that's flying around on the internet now is pelvic floor PT.
Yeah.
And, I do think that pelvic floor PT is great, and I
Yes.
think it has its uses. But I have had a lot of patients go to their gynecologist and be told, oh, well, you have incontinence, you just need pelvic floor PT.
Yeah.
And I'm like, yes, and. So talk to us more about what can be done for
Yes.
somebody with either urge incontinence or stress incontinence,
Yeah.
like what you were talking about.
No, and I think that's a good point because you're right. Pelvic floor PT is a great option. It's a great non-surgical treatment option. But I think it's important for patients and women in general to know what are their options, right? I think where it gets tricky is when patients are being told this is the only option, just deal with it because that's not
Exactly.
correct. And so I think what I tell patients, for example, when I'm seeing patients in my office, the first day, I of course start with a good history, a very thorough history, and maybe they came to me for urinary incontinence, but once we go through the history, because I asked them about bowel symptoms, I asked them if they have a bulge, asked them about their sexual habits, I asked them about whether they have pain with intercourse or any other associated symptoms. After a full detailed history, you realize there's so many other things that they didn't even know was an issue or didn't even think that there was help about this, right? So I
Yes,
think it's
yes.
very important to talk about those. So then I go ahead and do a detailed exam because, again, women could come to me thinking that they have urinary leakage, but when I'm doing an exam, I see there's a lot of laxity and they have a significant amount of prolapse, which, again, just doing PT alone may not be the best treatment options. So to answer your question about what other options do we have, so for most of the conditions that I treat, there are some amazing non-surgical or what we call conservative treatment options. And there are also some amazing surgical options. So pelvic floor PT is, of course, one of the conservative treatment options. And for the right patients, it can be a game changer. But
Sure.
something to know is that pelvic floor PT is like working out at the gym. You don't go to the gym one day, do a great workout, and lose 10 pounds, right? It's something that you have to keep at it. You have to be doing it, regularly, rigorously, not just the day that you're seeing your PT, but every day, and sometimes even multiple times a day. And it takes
Right.
time. So I tell patients who are motivated, that's the most important thing, is like you need a motivated patient who's ready to do the work. And I tell
Yeah.
them, look, a good PT for 2 to 3 months is when you really start seeing the results. But if you're
Yes.
somebody who's truly suffering and wants something like a definitive treatment option, then that's when we talk about the different surgical options. And the
Right.
amazing thing about the field is like most of my surgeries right now is what we call minimally invasive, which means that we
Right.
use tiny incisions and sometimes no incision at all. And patients do great. I would say 98, if not 99% of my patients go home the same day. Recovery is amazing. They're back on their feet, and the success rates are really, really good. So I think it's definitely worth discussing those options. So if you're talking
Sure.
to your OBGYN or primary care doctor who may not be very familiar with some of these options, I think it's very important that you get referred to maybe a urogynecologist, somebody who can discuss this, and then you decide if this is for you or not. But I think it's
Yeah.
important to know what your options are.
Yeah, yeah, absolutely. And do you recommend vaginal estrogen for your patients as well?
100%, 1,000%. Thank you. And thank you so much for bringing that up because, so a significant portion of my patients are menopausal. And as you know, right, I mean, I hear this all the time, like patients will come and be like, oh my God, I was fine. And then I went through menopause and I'm falling apart. Well, it's not that they're falling apart, but yes, changes happen in our body as we go through menopause. It's a different stage, right? With the decrease in estrogen, there are anatomical changes that can happen in our pelvic area, whether it's in the vagina, the labia minora, the labia majora, the bladder, the urethra. So the bladder is the organ that holds urine, and of course, urethra is the pipe through which urine comes out. And so in our field, the signs and symptoms that develop as a result of this change of hormone is what we call the genitourinary syndrome of menopause. It's a very complicated name, essentially to describe like all the things that happens in menopause, right? Whether it's the vaginal dryness, the burning, the discomfort, the urinary urgency, frequency, the pain with intercourse. So all those things. So vaginal estrogen can be a lifesaver for some of these patients, right?
Yeah,
And I
no, I agree
think
with that.
the discussion or some of the concerns that I hear, which sometimes really upsets me because, for so long, women have been scared, or not women scared, but we as providers have scared them saying that, okay, you know what, hormones are bad, right? Hormones can cause blood clots, like hormones can cause breast cancer and this problem and that problem. And yes, for some patients, it may not be a good option, but something that I always tell patients is vaginal estrogen is completely different than oral estrogen. So vaginal estrogen is
Absolutely.
a cream. So the amount that gets absorbed in your blood is so low that it doesn't have the same side effect as taking an oral pill. But for some of my
Right.
patient population, it can make such a difference. So I
Yes.
absolutely recommend using it for the right patient. It can save them from all the different symptoms that we talked about and also recurrent UTIs, which can be a real problem for many women.
Yes, absolutely. And I just want to mention here is just because you're taking and I don't generally use oral estrogen for my
Mhm,
patients that are in menopause. I generally recommend a topical option,
mhm,
like a
mhm.
patch or a cream or a gel. But but those patients, even though they're on a systemic estrogen, they
Yeah,
can still benefit from that vaginal estrogen. And so
absolutely.
I encourage people actually to do
Yes. And
both. And
it's
if
been
they if they can't take systemic estrogen, they can still take topical estrogen. Even if they are on a cancer treatment, they can still take it.
Absolutely. And I remember when I first started my practice, of course, when you're young and you don't have a lot of experience, you're a little bit more hesitant. And I remember reaching out to my oncology colleagues all the time, being like, hey, this person has had prior history of breast cancer, very remote history. Are you okay if I start them on some vaginal estrogen? And honestly, majority of the times they're totally fine. And
Yeah, unless
sometimes
they
if
don't
somebody,
know. Unless they don't know.
yes, exactly. And then, it's a discussion that I have with patients, right? I tell them exactly what the data is. And then together we come up with a plan with what they're comfortable with as well.
Right.
Because sometimes some of this, like somebody who's getting a UTI like every few weeks, putting them
That's
on vaginal
horrible.
estrogen, that's horrible. Putting them on vaginal estrogen, maybe even for a few months, could make them kind of break that phase, as opposed to that theoretical risk that maybe they'll develop a blood clot or a breast cancer. So again, it's a discussion that we have together.
Yeah, yeah. So how do you decide who is going to need surgery?
So like I said, before, when I see patients, depending on what conditions they're coming to me for, I do a full thorough history, I do an exam, and then in my practice, I actually talk about all the different treatment options for them, whether it's surgical, whether it's non-surgical. And sometimes, truth be told, some patients come to me and I tell them, like, look, you have a little bit of prolapse, but it's really not that bad. Observation is always another option, right? So, none of these conditions that I treat are life-threatening. So surgery, again, there's some patients who come to me because maybe they've been suffering with it for a long time. They've tried some of the conservative measures themselves, maybe with a different provider, and now they're really committed to just kind of take care of it once and for all. So they want something like a definite solution. So that's my easy patients where, I tell them that, yes, okay, fine, let's see what surgery would be best for you, and then we go with that. There's some patients who are a little bit more hesitant because, again, they've been told that, okay, surgeries are complicated. You're going to have lots of complications. God forbid, your provider mentions mesh, because that's another bad word that
Oh,
comes
mesh
up.
is a bad word.
Yes. So we spend a significant amount of time talking about the real data. What are the pros? What are the cons? And honestly, like I feel in my practice, once patients actually know the real data and then we have an open discussion, their patients are pretty savvy. They themselves realize that, look, surgery is the right option for me or not. And then I kind of help guide them, kind of, navigate that journey. And then there are patients that I'll say, like, surgery is not a good option for you, maybe because they have multiple other health problems, and which makes them not a great surgical candidate, or where I feel that, what, I'm not going to be able to solve their problem to a point where they're going to be happy with it. So I'll tell them honestly, like, look, surgery is not the best option for you.
Got it. Well, so earlier we were talking about a new nerve stimulator that's an implantable device, and I'm
Yes.
fascinated to hear more about that because we just mentioned it in passing, and I was like, ooh, I want to know more
Yes.
because anything that's that effective and that it's new,
Yeah.
but it's like, wow, the results are phenomenal.
Yeah.
So tell us more.
Yeah. So I think, what you're referring to is something called sacral neuromodulation. So it's a relatively new device that we have. And the idea is, this device helps stimulate your sacral nerves. So our S3 nerve is what controls our bladder. And so we use that for that particular device. And the good thing about this sacral neuromodulation is it is FDA approved for patients who are suffering from overactive bladder. So those are the patients who have urgency, frequency, not being able to make it to the bathroom. It's also FDA approved for patients who have bowel leakage. So patients who are not able to control
Oh,
stool, as well as women who have urinary retention, meaning that they're not able to empty their bladder. So as you can see, there are multiple indications,
yeah,
and
yeah.
many of our patients, or many of my patients, who have urinary urgency frequency, also have fecal incontinence or fecal urgency, which is essentially when they have that urge to go to have a bowel movement, they cannot hold it. And you can imagine like how distressing that can be for patients. Like if you think
Horrible.
leaking urine is bad, for somebody who leaks stool and not able to control it, I mean, it's truly, it breaks my heart
Devastating.
when I think about
Devastating.
it. It's
Yeah.
devastating. They isolate themselves. They don't want to go anywhere. They're embarrassed. They're even embarrassed to let their partners or family members know because, it's not something that you want to talk about. So
Yeah.
this device, the sacral neuromodulation, there are two companies that makes the device. Medtronic is one company, and then Exonics is another company. So I use the one by Medtronic. It has truly been a game changer. I think, when it was first developed, we're still kind of learning how to do it, how to optimize it. But now, honestly, like, it's a 10-15 minute procedure, and it has been
Whoa.
significantly changing patients' quality of life. I love it. It's one of my favorite procedures to do because it's so easy, it's so simple. But the best part is, like, literally patients come to me in the office for their post-op visit, and they're like, oh my God, I can't believe I didn't do this earlier. Because, in their mind, they're like, what are you putting in my body? But once they see the improvement, it's amazing. And then one more thing about the device is, the good thing is we do this procedure in 2 stages. And the reason for the 2 stage is, before we actually put in the permanent implant, patients actually have a little trial period where they get to see if this device is actually going to work for them. So the way, I consult patients is, well, if it doesn't work, then, we just remove everything and it's as if you never had it. So there's really no loss. But if it works for you, it can really be a game changer. So I love that procedure.
That's really
Yeah.
amazing.
And actually, one more plug for it. I am doing a patient education webinar about that device, and also like patients with OAB and fecal incontinence in early June. So,
Sweet.
I'll talk
Okay.
about it before. So I think for anybody who's
Yeah, yeah.
interested, it's free. It's patient education webinar. They're more than welcome to ask questions, and I'll be answering them.
Yeah, and we'll absolutely link to that
Yes.
in the comments for sure. So, talk to me about some misconceptions that people might have when they're thinking about going to see a urogynecologist.
That's an interesting question, but it does happen. I think the first thing is, because patients come to me and, the first thing they tell me is that, oh my God, I have been suffering with this for 5, 10, sometimes 20 years.
Oh,
Because, people always tell me that, oh, it's normal. You went through menopause. It's normal to leak urine. That everybody has that. Oh, you had a baby. Of course you're going to leak urine. That's normal. Oh, you had a child. Of course things are going to feel different. And what I tell patients is that, yes, age can be a risk factor. Certain life events can be a risk factor, but it's never normal. So, definitely somebody who is suffering from any of these conditions, what I would always urge them is, talk to your providers, whether that's your primary care doctor, your OBGYN. And if you have significant concerns, have them refer you to a specialist. Doesn't mean that the specialist is going to do anything, but at least have that conversation so you're aware of what the options are. So I think that's the first misconception. The second one is, and you probably get that too as a surgeon, I'm a urogynecologist, I'm a pelvic reconstructive surgeon. So of course patients think that, okay, you're a surgeon, all you want to do is surgery. And that's so not true. I mean, listen, I love surgery, but as we discussed today, there's some amazing non-surgical treatment options, and it's a discussion that we have. So if I have a patient who's very much like Dr. Noor, I know I just heard about all the options, but I really don't want to do surgery. I think, doing something a little bit more conservative is really the way for me to go. And that's perfectly fine. My job is not just to treat you, but also to educate you. And that is something I feel very strongly about. And that's completely okay. And, there are patients who come and we talk about all the options and they're like, you know what, I'll wait. And then they come back to me 2 years later, and that's totally fine as
that's
well.
totally fine. Yeah.
And then I think the last thing is, because I hear this all the time from patients, we go over everything and then they're like, well, but am I not too young to have this surgery? Or the opposite spectrum, like, am I not too old to have this surgery? And something I tell patients is, if you're suffering from it, right? So say if you're a 30-year-old who just had a baby and you're done with children, you love to take your children out, but every time you're in the park with your child or on the trampoline, you're leaking urine to the point where you hate going out anymore, right? Or if you are somebody who's in their 70s, you are petrified that you're going to go outside and not find a bathroom. So you're not going out with your family or friends. And, you missed your daughter's wedding, you missed your grandson's graduation. Why suffer? There's never a right time to have surgery or not. If you're suffering, talk to a specialist, know what your options are. And if this is what you need, then there's no right or wrong time. Do it when you need it. Really don't wait. So those are the 3 things I would say.
Okay. All right. Well, we are just about out of time. So tell me one final thing that you want the audience to take away from our discussion today.
Yeah, so I think I've said it multiple times, but I'll say it again. I think it's while age is a risk factor for a lot of the pelvic floor disorders that women suffer from, it's never normal to suffer from them. So I think if there's one thing that I want your audience to take from this is that pelvic floor disorders, whether it's urinary leakage, prolapse, urinary urgency, recurrent UTI, bladder pain, you name it, they can happen. And actually, they're more common than you think, but it's never normal. So talk to your providers, talk to your primary care doctor, have them refer you to a urogynecologist. If you're in my neighborhood, I'm happy to take care of you. But if not, there are a lot of us all over the country. So please find one of us and let's talk about what the treatment options are, and let's get you the help that you need.
That is absolutely fantastic. So, this has been Dr. Nabila Noor. You can find her on social media, including Facebook, LinkedIn, or Instagram at Dr. Nabila Noor. And do you have a website, dear?
It's funny you say that because it's actually in the works. So it should be going live in a few weeks. So I'll link it, of course, in my social media. But for now, that's where I am.
Okay, well, fantastic. And so your webinar that you're going to do, is it going to be on Facebook or is it going to be on Instagram?
So it's actually, I'm doing it in conjunction with the companies. There's two. So I have one coming up about pelvic organ prolapse, which is on May 14th. Excuse me. It's a Tuesday. It's at 6 p.m. It's anonymous. Actually, that one I already posted on my social media. So there's a link for patients to register. Or, you don't even have to be a patient. If you just want to know about it, you can register it. And then you're just going to log in. It's via Zoom. And then, you can put in questions. If you have something, it's all anonymous. It's really for education purposes. So that's on May 14th. And there's another one I'll be doing on overactive bladder and fecal incontinence. That's going to be on, I believe, June 4th. It's early June, the first week of June. But we're working on the marketing. So I'll put that link up soon as soon as it's ready. So those two are in the pipelines.
Okay. Well, thank you again for coming. This has been really great.
Thank you, Dr. Gibbs.
Yeah, I've learned a lot. So hopefully my audience has as well. And hopefully we will be hearing a lot more from you in the near future, because this is really, really great.
Thank you so much, Dr. Gibbs. I had a wonderful time. As we talked about, off the camera, there's so much that, we're learning about, and there's so much that women suffer silently. And I think, my specialty, pretty much the whole of my specialty is women suffering in silence. So I do want to talk about this. I do want to normalize the conversation and really to reach out to those who need me to let them know that, yes, there is help. So thank you for this opportunity.
Fantastic. All right. So, if you're not a physician, please keep in mind, in order to make treatment decisions for individuals, sometimes us doctors have to consider evidence that's not nearly as absolute as we would like. This discussion has not been meant to be medical advice, and you should consult your own physician for any medical issues or diagnoses that you may have. So this has been the Tuesday Live with Dr. Gibbs, and I am taking new patients in my consulting hormone practice, and hopefully we'll see you again next week for the Tuesday Live. I do have one announcement, which is the Master Your Metabolism CGM course that I am running closes tonight, and we will be starting with the first meeting of that tomorrow. So if you're interested, that's at www.danagibbsmd.com/join us. And I'll talk to you again next week. Okay, bye-bye.